Good evening. Hello, dear friends and colleagues. Today we are at the 4D 3.0 session. 4D means where we have detailed dialogue and discussion about Indian diabetes. For this, we have three eminent people from Khammam in the state of Telangana. First of all, I would like to welcome Dr. Pradeep Kumar Velugu. He is an endocrinologist practicing at Khammam and at Jagrut Super Specialty Hospitals. Hello, Dr. Pradeep Kumar.
Hi, sir.
Yeah.
How are you, sir?
Good. So, first, what do you think about metabolic health and what is your idea of metabolic health? So, that is what we are going to have a discussion about today. So, in endocrinologist terms, what do you mean by health?
Health means it is a physical, mental, and also in the endocrinologist perspective, there is a well-controlled sugar, hypertension, and lipid profile, and also cardiometabolic and kidney cardiovascular health is the metabolic health.
So do you believe that you stay in a healthy place? Do you have a good
Yes, sir.
air quality as well as a good weather in Khammam?
Yes, sir. Compared to Tier 1 and Tier 2 cities, we have a good air quality on.
Okay, so that's a wonderful thing about. So someday I would like to visit Khammam. I've just heard about it. The next speaker that I would like to welcome is Dr. V. Sitaraman, who is a cardiologist practicing at Sankalpa C Star Hospital, Nehru Nagar, Khammam. So, Dr. Sitaram, I would like to ask you about what is so special about Khammam. So, what is it that you like about the city? And
most thing is, when we work at a Hyderabad, as you said, most difficult and most what we kind of torturous traffic, sir. We had to lot of problem in traffic. We used to get a lot of wasting of time. I used to stay at when I was working in exams.
Okay.
So that was the biggest thing, and of course, air quality and many things. So in a good city.
Right. So I think that's good to know about a place that is not till now at least not besetted by traffic problems. So I think that's wonderful to hear. And the third speaker that we have, often the neglected part whenever we talk about diabetes, we have a nephrologist, Dr. Manoj Yalamudi. He is practicing as a renal transplant physician at Shri Kakatiya Kidney and Dialysis Hospital, Khammam. So I think I was reading about Khammam in. Hello, Dr. Manoj. I think you're in mute. Yeah. No, I think you are not audible. Yeah.
Sir,
Yeah,
hello.
So, yeah. You're audible. All right.
Yes, sir.
So what exactly is Khammam famous for? I heard about it being a good air, having a good air quality, a good weather, as well as a good traffic-free city. But is there something that you would like to tell us about Khammam?
Sir, one more thing is actually our food is very good, sir, actually, comparatively and compared to other places.
Oh, great.
So you find it very nice.
Okay, I think probably is there some fort there which I have heard about?
No, sir, no, nothing. It's
Okay,
it's in the middle of the state, actually, comparatively in the border state to the Andhra Pradesh.
No. Is there a fort, a famous fort?
A fort is there, sir. Actually, one Killa is there. Yes, Killa.
Yes. So I read about it, and it belongs to some Kakatiya dynasty, something.
Yes, sir.
Like
Yes, sir.
Bahubali, probably, because Bahubali seems to be heavily inspired from Kakatiya dynasty. And in Bahubali, I think all the actors were the sign of the best metabolic health that we have today. So I think coming to the topic that we have today, so let's move on to the topic. So we will be talking about metabolic health targets and techniques. So I think Dr. Pradeep has already spoken about what is his idea about metabolic health. So I think I would like to first ask Dr. Manoj, what do you think from the nephrologist perspective? What is metabolic health?
So just my colleague already told you, sir, actually to control our lipids, to control our weight, and to control our food habits, because all these things in the end will come to the kidney health also. So obesity, as we know, the component of metabolic health is the obesity, morbid obesity, and obesity. So these things, when a person is having a morbid obesity, it will definitely cause a lot of stress on kidneys, and which will lead to it's one of the cause of the CKD also, morbid obesity.
Absolutely.
So, and to control lipids, to control their weight, to control their food habits, and hypertension, diabetes, all these comes to, as a nephrology perspective, all these will come as a metabolic for kidney health, sir.
Okay. So I think that's your idea of metabolic health. And now moving to Dr. Sitaram. So what do you think? Why do you think a cardiologist must engage in securing a good metabolic health? So what particularly is an engagement per se of the view of cardiologist in keeping a good metabolic health?
So main thing is we look metabolic syndrome as we know this is a complex. When patient is diabetes or hypercholesterolemia, we usually consider the coronaries. Whenever we if the patient is having hypercholesterolemia or diabetes, we get a cases with a either atherosclerotic plaques or a thrombotic occlusions. So majority of the time the treating will not be a challenging for us. When it comes to the metabolic syndrome, patients they do have symptoms because of the obesity or because of the insulin test, whatever the reason, they come with a shortness of breath. Majority of the time, we struggle to treat the heart failure with a preserved ejection fraction. With the heart failure with the lower ejection fraction, beautiful drugs has come and definitely the quality of life and the longevity of life has improved. And with the coronary obstruction, we have the now coronary angioplasties, CABGs, so many newer technology has come to treat that. The second thing is the arrhythmias, especially the atrial fibrillation. So main challenge when we feel difficulty in these two areas. One is atrial fibrillation, which is causing again either cardioembolic strokes or a heart failure, at the heart failure with the preserved ejection fraction. So our main motto to treat these things is we have to target the targets of this metabolic syndrome so that we can have some sort of quality of life we can give to either heart failure with the preserved ejection fraction patients and the quality of life for a atrial fibrillation patients. These are the two challenges we usually face.
So, coming to Dr. Pradeep, I think I would like to ask you when we talk about metabolic health. So, when we talk about metabolic health, an important part of metabolic health seems to be the targets. So,
Yes.
when we talk about glycemic targets, so what kind of glycemic targets are you looking at, and other endocrine targets that you would look at when you are discussing a metabolic health in any patient?
In normal people, when we talk about metabolic health, the fasting glucose should be less than 100 milligram per deciliter. If he is any diabetic patient, he is already in taking treatment. Uh, Fasting blood sugar should be less than 130 milligram per deciliter, and postprandial should be less than 180 milligram per deciliter. But in normal individuals without any diabetes, less than 100 milligram per deciliter fasting is recommended. Coming to
Okay.
lipids, triglyceride should be less than 150 milligram per deciliter, and SDL should be more than 40 milligram per deciliter.
Right.
And also, coming to blood pressure, it should be in diabetic or non-diabetic, it should be less than 130 millimeters of mercury, whereas diastole should be less than 85 millimeters per mercury.
And would you
Uh,
like to keep some HbA1c target when we talk about metabolic health?
yes, sir. In non-diabetic patients, we should keep in the normal range, that is less than 5.6 percentage. In diabetic patients, it should be ideal to maintain less than 6.5 or at least below 7%.
Okay. And anything about visceral adiposity? So would you like to talk about it?
Yes.
The adiposity or
In
something like that?
yes, in Indians, it is more common, especially in South Asian and South Indians. In men and women, there are different targets are there. In men, it should be less than 90 centimeters waist circumference. In women, it should be less than 80 centimeters.
Right. That's an important part that I think you covered the glycemic targets. Partly you covered in even the dyslipidemic targets, and also you covered the central adiposity that we have, which we need to take care. Something about renal health, Dr. Manoj, could you enlighten us about what would be your metabolic targets? So, something about EGFR, something about urine albumin creatine ratio, something targets that you would like to keep in your patients to maintain a good metabolic health.
So, when it comes to nephrology, I think there is no difference to compared to as our endocrinologists are told. And
Right.
proteinuria wise, it should be normal targets only, sir. Normal persons, and we want to maintain less than 150 mg per deciliter for protein creatinine ratio, sir. 150 mg per day.
Okay. And anything about EGFR decline that we talk about? So the annual decline that we expect, or something that we need to keep a target that we shouldn't see too much of decline.
Sir, just like any normal person only, sir, I don't think there are any specific guidelines for nephrology as such, but
Okay.
we take a GFR decline 1 ml per deciliter per year, sir, actually, normal range.
Okay. Okay. Right. So I think some guidelines do say about more than 3 ml per minute decline probably contributes to a little bit of renal disease progression. Any idea about that? So
No, sir.
probably. Okay, so probably I think that would be a good number that we can look at. So 1 to 3 ml is something that we can, I think, keep it. So if it is progressing more than that, then probably we are looking towards a more derangement. So coming to cardiac perspectives, Dr. Sitaram, would you like to enlighten about the lipid targets in particular? And are there any specific cardiac markers that you would like to look out for, especially in patients who, where when we are trying to look at metabolic health, both in a normal person as well as in a diabetic person?
So as endocrinologist has clearly told that about the lipid things. So we just see the either prime we are targeting for a primary prevention or a secondary prevention. So secondary prevention, there is a established cardiovascular disease. So there obviously less than 70 we usually keep the LDL levels, and if it is the patient is are at least 50% of his baseline. If it is
Right.
in a primary prevention, we usually keep at least less than 100. If the patient has family history or any other risk factor, in that case also we usually target for either 50% of his base level or less
Right.
than 70. But on the triglyceride, we won't see much targets. Or like we won't be that stiff to chase the triglyceride as compared with the LDL. And of course,
Okay.
hypertension, obviously, we have to upper sprint definitely less than 120, only the good thing. It's very important for a heart failure as well as the coronary artery disease, both the diastolic and systolic BP, strict control. Whenever it's possible and feasible, we better to have the strict target on the hypertension aspect. And other than this, I have told you about the two things. One is the heart failure with a preserved ejection fraction, and this arrhythmias, especially the atrial fibrillation. So these inflammatory markers might help to predict in a future events. One thing. A second thing is the NT-proBNP. Whenever the patient is having significant symptoms and who's having this complex syndrome and the symptoms, and we are not pretty sure about the reason for the symptoms. Is it because of the microcirculation of coronaries problem or a problem with a heart failure preserved ejection fraction itself? So such cases, NT-proBNP will help. And of course, D-dimer also has whenever we have a thrombotic risks are in a cases of atrial fibrillation or flutter. In such cases also D-dimer, sometimes we take a factor to start any anticoagulation or to longevity of the using of anticoagulation. So these things we usually care.
So I think that's an important point that you told, that NT-proBNP and HSCRP seems to be good predictors of future events. So
Yes.
rather than for monitoring, I think it's more important that we need to make sure that at least we have to make it a good predictor of the future events. So that's something that we need to look into. So now that we have set the glycemic targets that we have, so endocrine targets, then we had nephrology targets, and then we had the cardiac targets. Uh, any particular point, Dr. Pradeep, would you like to talk about something about your thyroid, pituitary, and gonadal axis? So I think that's an important, often missed point, especially when we talk about metabolic health. Anything that you would like to talk about them?
Yes, sir. And especially in obesity, there is a slight increase in TSH levels. We will usually take in obese patients, we will treat only if severe obesity is there. We will treat only if it is more than 10. In with age also, it will increase. So we will treat only if it is more than 7 only. Coming to the gonadal axis, with metabolic syndrome, there can be primary hypogonadism or secondary hypogonadism in males. And especially in females, there is due to the insulin resistance part, there is a higher incidence of PCOS. So
Right.
that
So
will
I
be
think
there.
that's an important point that I think even a good sexual health is equally important, isn't it? That
Yes.
erectile dysfunction is very well treated, and that also seems to be an important indicator or marker of a good metabolic health. So I think these all put together actually could be a good target setup that we can keep. So we have glycemic targets, we have dyslipidemia related targets, we have EGFR and urine albumin creatine ratio related targets, and some predictors that can be thrown in to check whether how much kind of severity we are looking at and what kind of severity that we are looking at. So after coming to the metabolic targets, I would first like to ask about the core techniques that we can use to optimize these metabolic targets. So first coming to Dr. Manu, so what do you think are the lifestyle interventions that will help us to achieve these targets and also get a better outlook? So, before coming to pharmacological interventions, I think lifestyle interventions are very mandatory. So, what are things that you would like to advise to a patient that he wants to maintain his good metabolic health?
So, just like normal persons only, to like good eating habits, to quit smoking, and to control all blood sugars, to control his blood pressure, and frequent monitoring of his from kidney point of view, frequent monitoring of creatinine and serum creatinine, and urine tests, urine protein creatinine ratio. So, and especially if diabetics, our goal is like to maintain urine albumin creatinine ratio is to less than 30 mg per gram, and if they are in the microalbuminuria range, that is in between 30 to 300, then we need to start them like to control ARBs or AC inhibitors and all these things. And all these things we have to do, and to decrease the severity of the
Yeah,
problems.
Dr. Manoj will definitely discuss about various pharmacological interventions. But before that, I would like to enlighten. I would like you to enlighten us about lifestyle interventions that we can do. So, anything that you would like to talk about sodium restriction or something that would help them to maintain their good metabolic health, especially from the renal perspective.
So to uh, first and foremost is to quit smoking and to quit drinking alcohol consumption. And the
Right.
other thing is regular exercises, like at least 30 minutes or 45 minutes of walk,
Okay.
and to maintain blood pressure, as Sir told, within 130 by 85
Right.
mmHg, and
Right.
sugars has to be under control, as Sir said, less than 110 mg per deciliter. All these thing measures we advise the patients.
Okay. And Dr. Sitaram, coming to you, what do you think would be a good lifestyle intervention that you would like to ask your patients? So, anything about sodium or something about any other particular measures that you would like to talk about?
Yeah, so when it comes to the metabolic syndrome, we usually look at the lipid profile. I mean, lipid parameters is more problematic, sir. So we usually advise not to use a trans fatty acid as much as possible. Better to avoid completely trans fatty acid like any junk foods. And
Right.
using poly or mono unsaturated fatty acids using will thing one thing. Now
Okay.
obviously the physical activity he requires for any cases to have the cardiac depends on his metabolic efforts, how much he can do depends on that. We advise them for a metabolic activities.
Right.
And of course, as you said, the table salt must be less than 5 grams. Those things we need
Right.
to for sure, for
Right.
especially in case of heart failure patients.
Right. So I think that's an important point about trans fatty acids that you mentioned about here. So that's often missed by most of our patients. So I think it can even be easily be taken care of just by reading the food label. So if the patient just reads the food label that's given behind any packet item, you can actually search for what amount of trans fat is there. And if they restrict their trans fat consumption, I think it does help. And another important point that you made is increasing the use of polyunsaturated fatty acids. So that's an important take-home message that we need to take or give to our patients. So, Dr. Pradeep, any more points that you would like to advise? Some lifestyle interventions that you would like to guide the patients?
If they're especially looking for any weight loss, we should restrict the calories as well as coming to the carbohydrates portion. It should be around 50 to 60%, not more than 60% of the your calories should be from carbohydrates.
Okay.
Proteins also very important
Any
because
particular form of carbohydrate that you would like them to prefer? Simple carbohydrates, would you like them
yes,
out to avoid or something like that?
we will prefer more complex carbohydrates. We will avoid processed and ultra processed foods and
For
also
the
avoid
sake of
any.
our physicians, could you just enlist a few things about what do you mean by complex carbohydrates and something what do you mean by simple carbohydrates?
Complex carbohydrates are difficult to digest. They contain more
Yes.
fiber compared to simple carbohydrates, and
Right.
simple carbohydrates are very easy to digest, and they will cause more postprandial spike compared to complex carbohydrates.
Okay.
That will increase the insulin resistance part.
Okay. Okay. So you're talking something about proteins.
So, proteins also essential because protein taking less amount of protein will lead to proteolysis and muscle loss. That will increase the postprandial burden of the patient. So at
Okay.
least 20 to 20% of energy should be coming from proteins, and 25 to 30% of energy should come from fats.
Okay. And anything about fiber that you would like to enlighten? Is there
Yes,
still a role of fiber, or it's okay if the
yes,
patient?
sir.
Okay.
At least
So
14 grams of fiber should be there for 1,000 calories of diet.
okay, so that's an important point. So I think a balanced meal of diet where it shouldn't be specifically carbohydrate heavy. Rather, it should be mix of all nutrients with a special focus on both complex carbohydrates and also focus on proteins as well as healthy fats, as Dr. Sitaram said, and also focus on fiber intake. And I think, Dr. Pradeep, would you also like to advise them about their sleep patterns? So, because India is a very sleep poor country, so that's what has been shown in multiple studies, and even we see around that even our kids are not sleeping as much as they need to sleep. So, why it is important that sleep is important, and is there a relation of sleep with or poor sleep with high cortisol, and does it contribute overall to the stress and atherosclerosis? Would you like to
Yes.
elaborate on that?
Yes. At least 6 to 8 hours of sleep should be there. That is also continuous sleep. Uh, if there is any sleep disruption or any, mostly in the night workers, or any disruption in the sleep cycle, that will lead to disruption of the circadian rhythm of the most of the hormones like cortisol, and also it will increase the insulin resistance also if there is any sleep disruption or any change in the sleep cycle.
Okay,
So that will worsen the metabolic health of the patient.
okay, okay. So that's an important point. And anything about stress modulation that Dr. Sitaram, would you like to tell us about? Because
Yeah.
nowadays, even we see young children who are stressed out. So I think it's a new thing that is coming of age.
As just we discussed, Dr. Pradeep, about the sleep. So sleep is, I mean, we look into very important, especially as we target the whenever we chasing the blood pressures, especially in a complex syndromes like metabolic, we need to have a sufficient NREM, because there is a dipping and non-dipping pattern. We have read about these things. So
Right.
majority of the uncontrolled hypertension and the insulin resistance, this is very one of the predictor for things. So whenever a patient is not controlling his blood pressure, means his dipping pattern is not sufficient. So whenever patient is not having sufficient dipping, means he do have the lack of sleep, and that will promote this diabetes as well as the complex symptoms like a metabolic syndrome. So next comes to the stress. So obviously the stress is the another, now it became a one of the most complex risk factor. We can't quantify it. So whenever we ask the patient or we ask the relatives, friends, we ask them to reduce the stress, relieve the stress, but these things somehow now aerobics and this yoga and these things has significant role. Of course, people who has a good financial well, I mean financially healthy people, those they are really doing well with taking help of either yoga or this aerobics or dance, whatever the things which makes them the stress level is really making good outcomes also. So that might one thing to relieve. Other than that, we can't quantify it. So one thing is about the sleep is definitely reduce the
Right.
stress, I guess.
Right. And is there some data about heart rate variability and stress so that you can
Ah,
highlight
yes,
that?
yes, as you have rightly mentioned, sir. Because majority of the this watches is there. No, we call it the
Absolutely. Absolutely.
the keep comes with the only their symptom is because of their variability in their heart rate. They just
Okay.
see that those graphs also coming in these digital watches.
Right.
So they just might read in their internet or something. They just come with those graphs. So is that any significant? So definitely like a consistent lower heart rate always will have the longevity. We know about it. Always the more fluctuating heart rate are more rates are always higher rates always makes the cardiac events more. So sudden cardiac death also higher in such cases only, and heart failures, arrhythmias like atrial fibrillation also more with such cases only. So that much we can make them understand, and we can ask them to take this yoga or any physical activity or any mental like music or those things we usually advise that you rightly mentioned.
Right. So that's an important point. And even in animal kingdom, I think it's always the tortoise which has the slowest heart rate and probably has the longest life. So I think
Yes.
just as in the tortoise and hare race that we heard about, I think it's important that here we need to be more like a tortoise rather than like the hare. And I think that would also help us maintain the metabolic health. Coming to you, Dr. Manoj, I think would you like to elaborate about the RAS role of RAS and where we can intervene it pharmacologically? So, what are the drugs that are available with us today to maintain this metabolic health, and what's the role of RAS system, and how can you target the RAS system and get good benefits in your metabolic profile?
Sir, the metabolic syndrome contains obesity and insulin resistance. So it causes hyperinsulinemia is the root cause of all these things, and which causes decreased tubuloglomerular feedback, which causes arterial vasodilation, and which leads to hyperfiltration in the glomerulizer. So,
Okay.
RAS is the renin-angiotensin blockade is the best treatment available for us with the lot of evidence. And we also have AC inhibitors, and AC inhibitors and ARBs will come under this RAS blockade. And along with that, we also have newer drugs like phenylalanine, all these drugs are comes under RAS blockade. So this is the first and foremost treatment for from kidney point of view to decrease the proteinuria, because these will decrease the hyperfiltration of the glomerulizer.
So for RAS blockade, do you think ACE-ARB are the first line of drugs or phenylketonuria should be the first line of drugs?
So,
Because this is we are
as of
targeting
now, we
patients
start
that
with
are
the ACE inhibitors or ARBs, sir.
okay.
So
All right.
phenylalanine is an add-on drug, sir, actually.
Okay, so that's an important key message that I would like to tell our physicians that the first line of drugs still till today even remains the ACE inhibitors or ARBs, select depending on your choice of patients, and after that an add-on drug would be. So coming to the glycemic perspective, so any drugs that have been established as good alternatives to yield a good glycemic benefit as well as improve metabolic benefit. So, Dr. Pradeep, over to you.
Yes, sir. Initially, metformin is the only drug which has both glycemic and some modest amount of weight loss, around 4 to 5 kgs. It has
Right.
some metabolic benefits. Uh, Now newer drugs came, especially GLP-1 analogs and SGLT2 inhibitors. These
Right.
are the two drug categories which has some amount of weight loss in with SGLT2 inhibitors, and also there is a lipolysis also there with SGLT2 inhibitors.
Okay.
Most of the metabolic benefits are with GLP-1 analogs because of the more amount of weight loss.
Okay. So, anything about GLP-1 analogs? So, for the sake of audience, would you like to elaborate what are the GLP analogs and what are the newer GLP analogs that are available and how they are a little bit different? Can you elaborate about it?
Older GLP-1 analogs are initially there is exenatide followed by liraglutide,
True.
dulaglutide. Now we have semaglutide widely available, which
Right.
is only acts on the GLP-1 receptor, whereas newer drugs like tirzepatide, which acts on the both GLP-1 and also GAP GAP receptor.
Right. Right.
And we
Right.
have also now coming triple receptor antagonists. We will uh, retatrutide, which
Right.
acts on the GLP-1 receptor, glucagon receptor, and also GIP receptors.
Okay. So I think semaglutide seems to be a single incretin-based therapy, and I think so. You can say that the tirzepatide is twin cretin, and now probably in few more years, probably we'll have a trin cretin, so which will act on the all the three incretins. So I think there's an advantage with GLP-1 and SGLT2 to provide our metabolic, but our old friend metformin still remains an important ally to till this date and can still be used. Anything about statins per se, Dr. Sitaram? What is your stay about statins in helping us achieve a good metabolic health? And do you think are they still useful, or you need newer drugs like various other drugs that are available to target dyslipidemia?
Definitely, sir. I mean, whenever we regularly practice, hardly, I mean, statins will be sufficient to chase our targets. Rarely we use a newer marker like HMI or PCSK9 or newer drugs are coming. But rarely we use, majority of the time, usually comfortable with a statins only. And
Right.
other thing is, as you mentioned about the RAS, we are very comfortable now with ARNI. So
Right.
we are happy with the ARNI after like now it's an AC. Those were target overrated now. ARNI is there. And another
Right.
thing is Saraglitazole. I mean, when we were doing when you were MD days, Saraglitazole used to talk a lot. I mean,
Right.
you must have learned about the Saraglitazole, about this glycemic control and the metabolic control, because this molecule has we in APA books those time used to read. Now, anyways, we are not practicing. But
Right.
for statin, another thing is about statin. I haven't seen about the using statin having this problem with a new onset diabetes. Though we have
Right.
written this
Right.
thing, I mean, literatures.
Right.
But our whenever we treat either primary prevention or a secondary prevention, sir, we don't have much problem to chase the LDL or the total cholesterol.
Right.
Rarely we might use the histamine in couple of cases. Now PCSK also we are using.
I think statin seems to be a good enough drug for majority of our patients, but in certain group of patients, probably ezetimibe or PSK9 inhibitors would be playing a role. But otherwise,
Exactly.
statin still seems to be the mainstay that we have. A word that you spoke about ARNI. So, would you like to treat it more for primary prevention or for heart failure reduction? That is what I would like to ask you over here.
So this
So,
is definitely for secondary, sir. I mean, this is major in a heart failure with the reduced ejection fraction only. In the heart
right,
failure with preserved also has not very strong evidence as a like reduced ejection fraction. So
right,
definitely this is a secondary only. But
right.
as Manoj sir has mentioned about whenever primary prevention, definitely the AC will be the take a first choice.
Right. So that's an important key message over here that ARNI is a important part of the RAS blockade, but I think the primary thing still seems to be ACE inhibitors and ARBs. Why we are discussing this is because lots of our patients unfortunately come from unaffordable backgrounds, and what happens is suddenly the thought about putting on highly costly drugs. But first, I think we still have good cheaper drugs that are available in our kitty, and they equally provide a good care in most of our patients. Would you like to agree with this, Dr. Manoj?
Yes, sir. Of course, sir. Yes, sir.
Yes, so I think that's an important message that yes, there still are old drugs which still are our ally, and they do benefit in most of our patients. So I think we have spoken about pharmacological interventions that we have over here. Where when we can talk about RAS blockade, we can talk about using SGLT2 inhibitors, using statins, selectively also using GLP-1 receptor agonist for their visceral fat reduction. A question that I would like to ask Dr. Pradeep is, I think still there is a little bit of doubt among certain physicians that GLP-1 analogs, they are more causing muscle mass reduction and not just fat mass reduction or visceral fat. So any say on that? And that's an important point that is often commonly discussed, and lots of physicians do have questions regarding that. Anything that you would like to talk about that?
Yes, sir. Due to GLP-1 receptor agonist, there is a decrease in appetite and early satiety. So
Right.
overall reduction in calories is there. So along with the fat, there is a muscle mass loss also there.
Okay.
If you don't exercise and take adequate amount of protein.
So I think resistance training is an important add-on that you can advise most of your patients who have been started on GLP-1 receptor agonists. So I think we have spoken about the metabolic targets. We have little bit spoken about the pharmacological therapies, and after that, we are going to talk about some cases for each of you. So I think I am an endocrinologist, and I have a little bit soft corner about for endocrinologist. So that's why I would like to start my first case with an endocrinologist. So I think this is a case for you, Dr. Pradeep. So I'd read it out for you, and I would like you to share your inputs and what would be your mechanism of action in this particular case and what you would like to do. So she's a 39-year-old woman with obesity, and BMI is about 37 kilogram per meter square. HbA1c is 6.2%. So that means she's a pre-diabetic. She has dyslipidemia with LDL somewhere about more than 130. Mild PSA like symptoms with irregularity in her menses. She does report low energy. She also has recent weight gain despite multiple dietary attempts. And how do you assess this patient? So what are the key important parameters you would like to talk about in this particular patient?
She has menstrual irregularities and also morbid obesity is there, sir. Grade 3
Right.
obesity is there.
Right.
So, and also she HbA1c is in the pre-diabetes range. So definitely the underlying physiology should be insulin resistance. We will
Right.
once again check HOMA-IR and
Right.
to know the insulin resistance. After that,
Okay.
we will also see any liver fat is there
Okay.
or any PCOD changes are there in the ultrasound scan.
Right.
So if there is PCOD is there with insulin resistance is there, then it is most probably PCOD with metabolic phenotype variety. So once we reduce the insulin resistance component, then automatically our menstrual cycles will be normalized.
Right.
So to target that, best therapy is lifestyle therapy with
Right.
calorie restricted diet and with uh, exercise, and also along with lifestyle interventions. If the patient is affordable, we can advise GLP-1 receptor analogs. If the patient
Okay.
is not affordable, then we will start with metformin. We can add on any SGLT2 inhibitors for weight loss.
So any further mechanisms that you would like to investigate this patient? So would you like to this patient to undergo some thyroid profile tests or some androgen parameters that you would like to address and you would like to talk about in this particular patient?
Yes, sir. She is having obesity, so I will also rule out any hypothyroidism. Is there any components of Cushing disease or Cushing syndrome are there? Any
Right.
exogenous steroid intake is there? And
Right.
also, I will look for any serum prolactin levels and
Right.
free testosterone index or total testosterone with SHBG component also to look for any hyperandrogenism.
Okay. Okay. So I think you have started her on GLP-1 analog. You have ruled out most of the things, and now she comes to you. And what kind of weight reduction targets would you keep in this patient? Because what happens is lots of patients are aggressively given some huge targets. But do you believe that we should go slow with the targets, or we should be very active with the targets?
I will advise initially only 7 to 10% of weight reduction initially.
Right.
So at least 10% reduction will uh, reduces the all metabolic components of that patient. It will decrease insulin resistance. Then slowly we will increase the targets to attain normal BMI levels.
Okay, so that's an important message that I think we have to keep targets that are comparatively achievable, and that helps the patient achieve a good, easy targets, and that doesn't depress or guilt the patient. Because if you give a very huge targets, what happens is these patients get depressed and they just quit even before starting on with the treatment in this group of patients. So I think those are an important insights that you spoke about in this case, Dr. Pradeep. Now, the case I would like to discuss with is Dr. Sitaram. So I'd like to give you this case. First, I would like to ask you how would you approach, assess, and investigate this patient, and then we'll be talking about what are the diabetic or what are the treatment plan of action that you would have. So this is a 55-year-old male with a BMI of 32 kilogram per meter square. He's hypertensive. He has dyslipidemia. His HbA1c is about 7.8%. His eGFR is 65, and he has NYHA class 2 exertional dyspnea. So, what is it that you would like to advise, and what are the investigations that you would like to do in this patient first, and how do you assess this patient, Dr. Sitaram?
Yeah, so he has sufficient risk factors, sir. So first thing is we need to see the his cardiac status by doing stress test, as if he's able to do any treadmill. So we need to check that. If treadmill is fine, then we can assess. If treadmill is if he's not able to do, then we have to check for his alternative stress test. Still he doesn't, we can go for a CT angio also, as he's have a significant anginal equivalent symptoms also is there and risk factor is there. And sometimes we need to see the calcium score at the CT scan also. That also will help us to make a treatment plan as well. So these are the main things we think. If any positive in stress test or a stress equivalent test or a higher calcium score, then we may need to evaluate his coronaries also by doing CT angiogram or a convention coronary angiogram. If any significant coronary artery disease, then we need to revascularize, depends on his symptomatic status as well as the coronary disease burden. And that is one aspect about the interventions. The second thing is the morbid obese, so we need to make them to reduce the weight. That, as Sarah has clearly mentioned about the how to reduce the weight and those things. And hypertension target, we have to keep at least 130 systolic BP and less than 85 of the diastolic blood pressure. And if he's tolerating statins well, then we better to keep his target of LDL is less than 70. And if he's not, then at least 50% of his baseline LDL control we need to have. HbA1c is fine, that is around 7.2 or something. So if it is
The 7 point, it's around 7.8. So HbA1c is around 7.8.
So we usually in a young, I mean, he's a 50 years gentleman, so better to keep his HbA1c less than 7.
Right.
So that is another thing that we can take help of the you people. And EGFR. So obviously we these are the things which we have given is one thing is primary prevention.
Right.
So as Sarah has mentioned about, we need to start AC inhibitors to chase the hypertension as well as the proteinuria prevention. And for a diabetic control, Sir has mentioned about the cardiovascular benefit with a GLP analog or a SGLT2 inhibitor, along with your glucose target drugs, and statin if it is required. The ezetimibe will be the next option, sir. So
He,
another thing,
yeah, he also has NYHA class 2. So, would you like to
yeah. So
enlighten?
so
Yeah,
So this class 2 symptom, is it because of heart failure with preserved ejection fracture, or
right.
any underlying coronary we need to see, sir. So if it any is it because of the any underlying coronary disease, then we need to revascularize him. If coronaries are good, then we need to see the any microcirculation dysfunction or a heart failure with preserved ejection fraction. So anyways, diuretics we give just for a symptomatic benefit, that will not have any mortality benefit, we know that. So for that sake, definitely we start either now newer drugs SGLT we are using now, and sometimes RNA also depends on patient symptoms we might use, not a standard. So
Right.
depends on his symptoms. Is it because of coronary problem or a heart failure? Depends on that we chase the symptoms.
Right. And any thing that you would like to enlighten us about the global strain pattern that is there in the Todiko that could be a
Yeah,
marker of
yeah, yeah.
the
This is another thing to
cardiovascular,
diagnose the heart failure with a preserved ejection fraction again.
right?
So this also will have the. This is one of the predictor for a future event, both the longevity of the life as well as the quality of life. Both it will give. So GLS less than 15 also will make the future heart failure chances will be higher. So such cases, usually this primary prevention will be better to use the beta blockers and the AC inhibitor in such cases.
Okay. So that's an important point that you have highlighted that I think based on case to case basis, I think a good glycemic control, addition of statins, addition of antihypertensives, and evaluating his cardiac status would be primary. And once that is done, I think you are taking a good care of his overall treatment plan and as well as the cardiac parameters that we have over here. So I think coming to our last case that we have today. So I think we have Dr. Manoj here. So we would like to discuss this case. So this is a 58-year-old man with type 2 diabetes. He also has hypertension, BMI of 33 kilogram per meter square. His urine albumin creatinine ratio is 180 milligram per gram, and EGFR is 64. And HbA1c is around 7.8%. He reports fatigue and nocturia. BP is 144 by 86. So first, I would like to ask Dr. Manoj, how would you investigate or assess this patient, and what is the treatment action plan that you would have in this patient?
Sir, I will start with the basic investigation, sir. The first and foremost is complete urine examination. Then I will go with spot urine protein creatinine ratio or spot urine albumin creatinine ratio, sir. Then again, I will do one serum creatinine and serum albumin, and I will do lipid profile test, and I will check her BP,
Okay.
and uh, I will, as our endocrinologist sir has already told, so fasting and post lunch to measure her glycemic levels.
Right.
And accordingly, if the proteinuria is high, I will start with AC inhibitors or ARBs, sir, initially, and I will ask her to take lifestyle modifications as a first step.
Right.
Then
In investigations,
any
yeah, just a moment. We'll come to the pharmacological interventions, but in investigations, we would definitely come to pharmacological interventions. But in investigations, would you like to talk something about retinal screening? Is there importance of doing a retinal screening in this patient?
sir, which one, sir?
This patient, would you like to do some retinopathy screening in this patient?
Of course, definitely, sir. If you complete urine protein, if CUE or CUE there is any proteinuria, or
Right.
any albumin urine creatinine ratio shows any proteinuria, then I will definitely refer for retinopathy investigation. And if patient is diabetic for more than 5 years, I will routinely ask them to go retina checkup, sir. Definitely.
Right. So I think, and also retinopathy helps us to evaluate between
That
non-diabetic and diabetic kidney
it's
disease.
diabetic kidney disease,
That's an
yes, sir.
important advantage of doing a retinal screen in this.
Simple retina test, but it gives lot of information.
Absolutely, absolutely. And after we have investigated it, so now that you have made it clear that that's the way you investigate. So, what is your pharmacological approach? So, what is it that you would like to? Because this patient does have a blood pressure on the higher side. His HbA1c is also slightly on the higher side. So, what are the drugs that you would like to add on this to this patient?
Sir, first and foremost is like ACE inhibitors or ARBs, sir.
Okay.
Then if still the patient is having high blood pressures, then I will add other drugs like calcium channel blockers, like those drugs. And diabetic control, with these investigations and with this proteinuria and metabolic syndrome features, then I will add one DAPA, SGLT2 inhibitors, sir, as a primary drug after AC inhibitors or ARBs.
Right. So I think all of you, three of you, have enlightened on the fact that when we are treating anybody for their metabolic health, I think three drugs they form the key pathway. One is RAS blockade, the drugs that cause RAS blockade, that is ACE inhibitors and ARBs. Then comes the finerenone like drugs, and you have the SGLT2 inhibitors and GLP-1 analogs, and also concurrent use of statins. So that's an important point. And I think we have highlighted also about the lifestyle modifications that the patient needs to undergo. I think before ending the session that we have today, so I would like to take inputs from you, starting from Dr. Pradeep, then Dr. Sitaram, and then Dr. Manoj. What are the important checklists that you have in mind whenever you talk about metabolic health?
Yes, sir.
Dr. Pradeep, please.
Initially, we will check for any normal in clinical examination. We will see for any signs of insulin resistance, like acanthosis nigricans, any skin tags, or any central obesity is there, and we will check blood pressure. In biochemically, we will see for urine routine for any albuminuria and dyslipidemia, and also any MASLD components are there or not.
Okay. I think that's a good perspective that you have put in. Dr. Sitaram?
Yeah, as Sir has mentioned clearly that always prevention is better than cure, especially syndromes like this, because you don't have one thing to treat. You have you need to treat the dyslipidemia, you need to treat the pre-diabetic status, and we need to treat the cardiovascular event. So, as Sir was mentioned, so better to start with your lifestyle intervention. That will makes a lot of difference than going for a pharmacological intervention. So, usually we have that prevention kind of thing more things are than having the standard treating options.
Right. And Dr. Manoj, would you like to give us a checklist that what each patient as a diabetes, what are the nephrologist perspective that is often missed? So what is there that we do need to check, or a physician routinely needs to check to give a
Sir,
good
I will
optimal?
do apart from as our colleagues are told, actually. Apart from those, I will also do complete urine examination, and urine albumin creatinine ratio is a must from nephrology point of view, sir. And as you actually remembered us regarding retinopathy evaluation, and I will also do an ultrasound, sir, to check for any NFLDs like features,
Okay.
the polycystic ovarian syndrome like features also. In metabolic patients, I will also check for these things also, sir.
Okay. All right. So I think that was an intensive and exhaustive discussion of metabolic health and targets that we need to treat. So I think first we initially spoke about the target in treatments, where we spoke about the glycemic targets, the dyslipidemic targets. Then we spoke about the EGFR decline. We also spoke about dyslipidemia. Then we spoke a little bit about pharmacological interventions. And I think all three of you helped us in solving the case puzzle that we had today. So I think a heartfelt thanks to all three of you for joining in this discussion, and I think everybody would definitely benefit hearing to this. Thank you, Dr. Manoj.
Thank you,
Thank
sir.
you,
Thank you, sir.
Dr.
Thank you, sir.
Thank you,
Thank
Dr.
you.
Deep. Yeah, thank you very
Thank you,
much.
sir.
Yeah.
Thank you. Nice discussion. Thank you.